The next speaker is Dr. Anujeet Paul. He's a consultant at the BBI Foundation, Kolkata, and he would speak to you on the retina diseases which mimic glaucoma at the OCT and field.
Hello. So thank you so much, madam, for including me in this IC. Hopefully the slides will be working a little bit better this time. Right. So my topic in this IC is to describe some retinal conditions that mimic glaucoma both in OCT as well as in fundus findings. So long for all this time we've been just focusing on the optic disc, but I tried to ask all the audiences to just zoom out your vision, and now we'll have a look at the entire retina as a whole and try to relate the findings with what we have learned so far going forward. So in glaucoma, we are mostly concerned with the inner retinal layers, that is, like my previous speakers explained, the ganglion cell layer, nerve fiber layer, etc. But we must also consider the outer retinal layers, which plays a major role in describing retinal diseases involving glaucomatous changes. So that changes what we describe a healthy optic nerve from a disease optic nerve. So otherwise, distinct retinal diseases can mimic glaucoma in terms of their optic disc features, their visual field defects, their findings on OCT, or a combination of all three. So for the benefit of the audience, I've just described these features based on presentation as what we see a single time in our OPD, as well as those that we see on follow-up as sequelae cases. So starting off with congenital anomalies of the optic disc that may mimic glaucoma, we have optic disc pit, dyscoloboma, morning glory syndrome that may have large discs as well as large cups. So diagnosis like this for anyone is quite simple. We are looking at a very simple chorioretinal coloboma. This one doesn't have any extension into the macula or the optic disc, while this one does have some extension. It's very easy to rule these out, and we know what investigations to occur. But what about an optic disc coloboma or something that is very small, which gives us a very characteristic finding that may mimic a scotoma on visual fields? So a bowl-shaped excavation, which is often inferiorly with otherwise normal-shaped vessels, is an optic disc coloboma. The main feature that would differentiate it is its non-progressive nature over time from glaucoma. Once again, this is another very simple example that we can see. There is a small optic disc pit in an otherwise normal retina. None of us would mistake this for a glaucomatous disc or a glaucomatous cup. But what if it presented as something like this? Something that is obscuring our vision, something that is not very clear, that is shown with the black arrow over here. So it corresponds to a small area of neurosensory detachment, which is extending towards the margin of the optic disc and accumulation of subretinal fluid. This would differentiate it for us, whereas the fundus photo or the clinical examination might keep us in some doubt. The OCT over here helps us in differentiating these features. Once again, a very simple image that we see in the OPD. This is nothing other than morning glory syndrome with vessels radiating in a bowl-shaped manner from the optic disc. None of us would confuse this as a glaucomatous disc. But what if it presented in a slightly more obscure manner? What if it presented in a manner where it is partially and not totally complete? So these are usually large-sized discs with a central glial tuft and increased number of vessels that is radiating from the center of the disc. It may show some erroneous glaucomatous field changes like an enlarged blind spot, an area of partial superior or inferior scotoma. Once again, another very simple image that we see in our OPD. This is optic disc drusen. This is very easily found out on fundus examination. These are the autofluorescent images. This is the OCT image of something like this. But what if there are only few? What if this image, there is a small hotspot on B scan? It's an irregularly sized disc with a yellow lumpy bumpy pattern, sometimes in the periphery of the margin of the cup. B scan will show us an echogenic focus. So this is how we can sometimes differentiate optic disc drusen from an otherwise glaucomatous disc. Myopia has been covered in detail by my previous speakers, so I'll just touch upon that. Otherwise, tessellated fundus with peripapillary atrophy. This is where looking at the periphery beyond the macula helps us in case of myopic disc that we are confusing for glaucoma. So We already know the relation between primary open-angle glaucoma and myopia. These have large discs with large shallow cups and a thin neuroretinal rim. My previous speaker has explained the importance of GCIP measurement in such a case, which will help us differentiate pathological myopia from glaucomatous changes. Field effects can be variable, ranging from an arcuate scotoma to an enlarged blind spot as well. So this covers what we see on presentation. We can look at some features that we see on continuous follow-up. They may not mimic glaucoma in its initial presentation, but as we follow up these cases, sometimes they can mimic. So one classic example is retinitis pigmentosa, which was also covered in the previous talk as well. So in this case, we see diffuse pallor with a very notable triad of arterial attenuation and bony spicules. Taking a wider look at the fundus, looking for the periphery, looking for bony spicules in the periphery helps us differentiate, because in this cases, fields do not give us a reliable example. Retinal vascular occlusions have also been described due to their variation in RNFL defects, mimicking RNFL defects. So a diffuse pallor in CRVO, whereas localized pallor in BRVO can help us differentiate these cases from glaucomatous disc. Of course, finally, as a retina specialist, I must mention PRP mimicking glaucomatous disc if not seen in its entirety. So there have been numerous studies which have conjectural responses to the variation of RNFL defects post-PRP that we can see here, but the overall consensus is have a second look at the fundus, having a second look at PRP spots as well as the pallor or the RNFL at the disc in such a case can help us differentiate these cases. Finally, I would be remiss if I did not mention optic atrophy as a mimicker. Glaucomatous optic atrophy versus neurological versus other conditions should be also differentiated with a thorough examination. Thank you very much.
Thank you very much, Dr. Anujeet, for that very, very illuminating talk.